Hi, everybody. Welcome to our webinar from Radcliffe Cardiology. Today's program will focus on trial updates and future directions in cardiogenic shock. My name is Babar Basir. I'm an interventional cardiologist at Henry Ford Hospital, and I direct the acute MCS program. And it's my sincere pleasure that we're joined today by two close colleagues and friends who are fantastic faculty and will be joining us to further these discussions. First, we have Dr. Balimkiz Senman. She is a cardiology fellow at Duke University and is going to be discussing the trials that have been conducted so far in cardiogenic shock, particularly those with mechanical circulatory support. And Professor Jacob Møller, who is a professor at the Odense University in Denmark and has recently published a landmark trial, the Danger Shock trial. After our talks today, we'll have a discussion as well as an opportunity to provide a live question and answer. So feel free to use that prompt to answer or to ask any questions that you have. And I'll pass the microphone over to Dr. Senman.
Thank you so much, Dr. Basir, for that wonderful introduction. All right, these are my disclosures. I want to start with a quick timeline of the really three mechanical circulatory support devices that we will be discussing during the course of this webinar and the trials that have been evolved around them. So in 1953 was the first time ECMO cannulation was used in the OR setting for ASD closure as cardiopulmonary bypass support. It was 5 years later that the first publication around the use of balloon counterpulsation was published in the American Heart Journal. And it wasn't until the early 2000s that the microaxial pump Impella became approved for mechanical circulatory support use. The trials around these devices really started after this point with 2010 was the IABP Shock 1 trial, and 2012 with the IABP Shock 2 trial that we're all very familiar with. And then most recently, really in the last year, we also became acquainted with the ECLS Shock trial as well as the Danger Shock trial. So to have a small overview of these three trials before we head into the Danger Shock trial, the IABP Shock trial, the first one was a single center randomized control trial. The question at hand was the use of balloon counterpulsation in cardiogenic shock patients presenting with AMI. It had a small sample size of 45 patients, with 23 of them being in the balloon pump arm. The primary endpoint was a reduction in the Apache 2 score at 4 days after randomization. And all patients were loaded with aspirin, 250 milligrams IV pre-PCI. They all received GP2B3A inhibitors and were heparin loaded and then continued on a heparin infusion. The IABP was continued for a minimum of 48 hours for the 23 patients that were in the balloon pump arm. And this study showed that there was actually no change in the Apache score between the two groups, balloon pump versus no balloon pump. In terms of their secondary outcomes, there was no difference between cardiac index or interleukin-6 levels. BNP levels were significantly reduced at 2 days, but at day 4 of the after randomization, they actually lost their significance between the two groups. 2 years later, the IABP Shock 2 trial was published by Dr. Bailey and his group. This was a study that was conducted between 2009 and 2012. It was a multi-center randomized control trial with 37 centers in Germany. The question was the same of the use of balloon tensor pulsation in cardiogenic shock patients with presenting with AMI. They screened about 800 patients and ultimately had a sample size of 600 patients in total, 301 of them being in the balloon pump arm. Their primary endpoint was 30-day all-cause mortality. They included patients that presented with AMI and hypotension, also showing end organ dysfunction and a lactate greater than 2, and excluded patients that received CPR for greater than 30 minutes, had coma, had cardiogenic shock greater than 12 hours, PE, or PAD that would prevent the placement of the device. Balloon pump was placed immediately pre-IABP, immediately pre-PCI, or post-PCI, the timing at the discretion of the operator. And the pump was run at 1-to-1 until there was evidence of clinic stability, which they defined as systolic blood pressure greater than 90 without need for vasoactive agents. And for both groups, this was about a median of 3 days. The average lactate for the balloon pump group was 3.5 versus the control group was 4.7. And there was allowance for crossover if there was mechanical complication of AMI. 45% of their patients had CPR. At the end of their study, what they found was that with respect to mortality at 30 days, the two groups had no significant difference. In addition to this, they also had no significant difference in their CRP, lactate, or renal function. The ECLS shock trial was published within the last year, again by the Dr. Thiele and his group. This was a study that ran from 2019 to 2022. It was a multi-center randomized controlled trial, 44 centers that were between Germany and Slovenia. And the question this time was the use of ECMO in cardiogenic shock patients presenting with AMI. They had a sample size of 417 patients, 209 of them being in the study arm, and also had a primary endpoint of 30-day mortality. All these patients were planned for early revascularization, either by PCI or CABG, and inclusion criteria was AMI with hypotension and end organ dysfunction, and a lactate greater than 3. They excluded patients that had CPR for greater than 45 minutes, non-cardiac shock, CS greater than cardiogenic shock greater than 12 hours, and again, PAD that would prohibit the insertion of ECMO cannulas. About 50% of their patients had SCAI stage 3 and a lactate in either arm of about 7. Their ECMO cannulas ECMO was inserted at the index cath lab visit. And 78% of these patients actually had CPR with ROSC in less than 45 minutes. On average, the time to ROSC for patients who arrested was about 20 minutes. And in this study, they had a crossover rate of 12% for refractory shock. And once again, the findings were similar in that in this patient population presenting with cardiogenic shock in the setting of AMI, the insertion of ECMO did not show a mortality benefit at 30 days. There was also no difference in the duration of catecholamine therapy and time to hemodynamic stabilization between the two groups. There was, as expected, a higher degree of bleeding and peripheral vascular compromise in the ECLS group. This is a brief table that delineates the 3 studies in addition to danger shock with respect to some of their study design. I won't dwell too much into dangerous shock, as Dr. Møller will give us a much greater overview of this study. But there were some similarities and some differences in terms of dangerous shock as compared to prior studies. And I think most notably, as we all know, dangerous shock was about a 10 plus year study with an endpoint of 180 days all-cause mortality compared to its predecessors of 30-day cause mortality. And with that, I will actually pass on the torch to Dr. Møller so he can take us through danger shock.
Great pleasure to be able to share some of the thoughts on danger shock with you. These are my disclosures for this talk. So danger was an open label RCT. We had 14 centers. We started out more than 10 years ago in Denmark, and after about 5 years, we got Germany and lastly the UK on board and had 14 centers enrolling patients. Our target was 360 patients, and our hypothesis was that an early placement of an axial flow pump, being the Impeller CP, would improve outcome in shock patients. Our inclusion criteria was a STEMI. It was hypotension and also mandatory hypoperfusion with a lactate of more than 2.5. We did in all patients an imaging study before randomization to exclude contraindications and mechanical complications, and the ejection fraction had to be reduced. Randomization could be before PCI, it could be while in the cath lab, and it could be up to 12 hours after leaving the cath lab, depending on when shock was diagnosed, giving these criteria. So this is not a pre versus post PCI Impeller study. It was when shock was there, but when shock was diagnosed, we mandated that the Impeller was placed. We excluded comatose cardiac arrest, which was defined as a GCS score of less than 8, which is equal to whether a patient would be able to respond to verbal commands. We excluded right heart failure, and we excluded the mechanical complications. So as I said, it was when patients were randomized, we immediately placed the Impeller in the Impeller group, and in the control group, we went on with PCI and gave pressors inotropes if required. At any time, the patient could be escalated if the shock team in the room decided that. So in some of the most severe cases, we had the shock team there, we had the ECMO team in the room, and if the patient was randomized to control, the ECMO could be placed immediately there. And escalation to ECMO was not considered a crossover, but a secondary endpoint. Our primary endpoint was all-cause mortality at 180 days, which was based on the shock trial back in 2000 from Judith Hochman, where they didn't meet the endpoint until 6 months. I think many of you know this survival curve where we actually met the primary endpoint. We had a 12.7% absolute reduction of all-cause mortality with the numbers needed to treat of 8 patients. You all also know that these devices comes at a cost, and we saw more bleeding, we saw more limb ischemia, we saw more sepsis, but a little bit to our surprise, we also saw more renal replacement therapy, which is something we're trying to understand now in one of our sub-studies. So the question is really why did we succeed where the other trials failed? It could be due to the device that we utilized. It could be the phenotype we studied. And there's been a lot of discussion on the management also of the control patients. And I'll try to touch upon these three issues. For me, the phenotype is by far the most important. So just very simply, you can say that AMI shock can be a result of primarily LV failure. It can be biventricular failure. And then cardiac arrest really pollutes this area because the cardiac arrest patient is so difficult to distinguish from the more real or clean shock patient. We targeted the LV predominant shock patient in danger. And we did that because we don't believe that a support device can save the brain. This is data from our shock registry in Copenhagen and Odense in Denmark, where we have 1,700 patients with cardiogenic shock. And among those patients, we saw that patients that suffered cardiac arrest, the main reason for death is brain injury, opposed to the patient with the LV predominant shock, where it is refractory shock that is the leading cause of death. And as I said, we don't believe a support device placed maybe an hour or more after arrest can save the brain. What is really important from these data, we also learned that the time to death is fundamentally different here. So in the patient that will die from brain injury, we all know that it takes 5 to 7 days to complete the neuroprognostication in these patients, whereas the patient in refractory shock, they died on a median of 13 hours after calling the emergency service. Furthermore, when you look at lactate in these patients, it's quite different. So these are the same 1,700 patients. And if you take a lactate of, say, 5 in a patient with arrest, this means that is equal to a survival of 40%, whereas in a non-arrested patient, a lactate of 5 has a mortality of 60%. I think it's because the lactate in an arrested patient will reflect the oxygen depth that is created during the low flow, during the chest compression, whereas the patient that comes in without cardiac arrest, the lactate will really reflect what is going on at the moment there, and the cardiac output and the poor perfusion at the moment. And this is really important also when interpreting and comparing these data across studies, because if there's a lot of cardiac arrest in a study, the lactate will be higher in that. And if there's less cardiac arrest, the lactate will not be as high, but maybe even be more deadly. So for the device, I think they are fundamentally different. So the impeller will unload the heart. So the PVA, which equals myocardial oxygen consumption, will go down. And very importantly, in these patients, also the end diastolic pressure will go down. And this opposed to the ECMO, where the PVA often actually goes up because of the increased afterload. So the myocardium may even have a higher oxygen consumption. And again, very importantly, the end diastolic pressure will go up and wall stress will increase. I don't know if this is the cause for what happened beyond 30 days, because that was I think one of the really surprises of danger shock that we saw this continuing separation of survival curves. We will not have definitive insight to what is going on there and what the mechanism is, but it of course is it could be related to the differences in these devices where you may have more myocardial salvage with the impeller, but this is purely speculative to say that. Now, for the management, there was a lot of discussion also in the letters in the New England Journal of Medicine that was published about a month ago. 6 letters were chosen. I think the editor told me they almost had 40 letters. So this has really created a lot of discussion. And one thing that is discussed is the matter of treatment bias. And then there has been a lot of discussion about that danger had the highest ever reported 6 months mortality. And this was referred to by comparing danger shock to these other trials. They, for some reason, Euroshock and ECMO CS wasn't included, which both had the mortality of more than 60% in the control groups of AMI patients. But I think very importantly, these studies cannot really be compared because they are so different in the population. So, for example, for IABP shock 2 and culprit shock, about 25% of the population had a normal lactate at randomization. And as 50% of these patients had arrested, it would likely be the patients with the LV predominant shock that were more likely to have normal lactate. So different phenotype than what we studied. The ECLS shock had almost 80% cardiac arrest. So again, a very different phenotype. So just plainly comparing these patients is very difficult. The other thing is treatment bias, and that is something that is very likely in an open label study. And I don't know if it's because we were Vikings that the controls were managed more poorly. We tried to do it the right way. So we did have an ICU protocol that was also published at the New England Journal of Medicine. But more importantly, every time we escalated or de-escalated, this was based on a shock team discussion, and that was mandated also by the protocol. So I think the treatment of the controls reflects the way we treat patients in Denmark and Germany. And there's, of course, one very large difference here to the US that we didn't use balloon pumps. We just saw the results of the IABP shock 2 trial. And I think if the heart is really struggling, the balloon pump is not powerful enough. Whether there are other phenotypes that benefit, it should be studied. But I don't think more use of balloon pump would have changed our results. So for me, it's really the phenotype that and maybe the device that drives the effect. There will come out a lot of more data on this from the study here at ESC coming up in less than a month on September 2. We will publish a meta-analysis merging all the ECMO data and the data on impeller and tandem heart that will be presented by Professor Thiele as late-breaking clinical science at ESC. At TCT, we have submitted 4 abstracts, one on vasopressor use and lactate clearance that has some very interesting data. We'll try to dive into the kidney injury. We'll try to explain why there wasn't effect in women in the study, and we'll dive into the bleeding complications. AIDS will be discussed at AHA, and next year I'll hope that we'll start looking into longer-term follow-up. The study will never answer the question whether an impeller should be placed before or after PCI, because it was simply not designed to answer that question. We will not be able to answer why the kidney injury was higher in the impeller group, and the mechanism of effect beyond 30 days will also be speculative, as I already alluded to. Unfortunately, we didn't gather data on quality of life today. We would obviously have done that 12 years ago. We didn't. These data cannot be extrapolated to other shock phenotypes, either with AMI or without AMI. And lastly, whether the ECMO would have done as good or better than the impeller in our phenotype is also purely speculative. And with that, I'll be happy to take any questions.
Thank you so much. That was honestly just a really fantastic overview, covering 20 years of evolution of the management of cardiogenic shock. I think you highlighted some really, really important points. I think first and foremost, the differences amongst the patients, the different cardiogenic shock phenotypes. If we just use the word cardiogenic shock, it can be, such a heterogeneous cohort of patients. And then we subdivide it, commonly with an acute myocardial infarction. And then we go even further to STEMI, and now to patients with an EF of 40%. And Jacob, in DanGER, we included patients with a lactate greater than 2.5. And so, what ultimately happened, rightfully so, was we studied a very specific pool of patients where we were able to demonstrate that benefit. So I think maybe the first question, Jacob, if I can ask you, is, going forward, understanding the strengths and the limitations of the trial, who will you be using Impella in for AMI cardiogenic shock?
That's a difficult question. I think it's really important to make sure that the pathophysiology is there. So for me, it's really, really important that the cardiac output is low, because that is basically what these devices does. I know there's the unloading effect, but I think we have to have a measure that the cardiac output is low. We use a lot of echo. The LVOT VTI is a very simple way of looking at stroke volume, and it's just a way of selecting this. If you have the patient in the cath lab, measure the end diastolic pressure, make sure it's high, then you have certainty that something is going on. I'm sure there are cardiac arrest patients that can benefit from this, but I think you have to go a little bit further in the treatment and try to optimize them on presses and revascularize before putting the device in, because many of these patients will improve quite rapidly. But if they continue to be in shock with low cardiac output, there will be patients there that could benefit. But I think we need, again, more studies. But as I said, the meta-analysis coming out at ESC will also share some interesting light into this area.
No, it's fantastic. We're really excited about all of this future work. And so, Balim, you're really on the front lines. You're taking care of patients every single day within the ICU, and you see, how sick these patients are. And now we have a therapy that's, at the highest scientific rigor has been shown to improve mortality. How has danger shock changed your practice and your mindset on treating these patients?
Thank you for that question. I will preface this by saying, and it might be an unpopular opinion, but I've always been and still am a little bit of a MCS equalitarian, in that I do think that there's a time and place and a patient for all MCS. And I still, despite the negative trials that have come before danger shock and the positivity of danger shock, I still believe that. And to Dr. Møller's point is that, we have a very heterogeneous population, and we often take that heterogeneous population even within AMI shock and then apply a therapy and then hope for a positive result. I think what danger shock was able to do is really narrow that heterogeneous population a lot better in order to elicit a more defined population that might benefit from the device at hand. So I do think that I will continue to use, I've always used Impella, I'll continue to use when a cardiac output is struggling, when that is my primary objective for the patient who's in cardiogenic shock. But, we'll be thoughtful in terms of other pathophysiologies that might benefit from other supports as well. And I really do think that we do, moving forward, again, to Dr. Møller's point, we do need to be thoughtful in terms of how we design these studies so that we can better elicit the patient populations that will benefit from the different devices that we have at hand.
Yeah, very well said. I think that, it makes a lot of sense. We have lots of tools. We don't need to, we just need to find the right patients to use those tools in. So Jacob, I think, probably one of the biggest things that was discussed after danger was the competing risks. So we did save lives, number needed to treat of 8, but clearly, as you mentioned beautifully in your talk, there was a cost. And I think people understand vascular access complications and bleeding when using a large bore hemodynamic support device. But I think people were surprised, for example, when they saw the level of acute kidney injury that was there. And I know that, it's something that you will all be looking at very closely, but could you provide us some early insights onto what your thoughts are about this?
Yeah. We're working on these data, but the excess kidney injury is very real in the Impella group, and so a competing risk analysis still shows us that there's more kidney injury and more renal replacement therapy in those patients, and it's at least partly related to suction events. It's partly related to the P level of the device, and it's something we're trying to understand. There's an association to plasma-free hemoglobin, so some of it could be that the device, especially when running fast and maybe not being placed perfectly, create hemolysis that will harm the kidneys. So I think doing danger over, which I hope not to do, but we shouldn't have. We mandated 48 hours of unloading as much as possible. Today, I would be less aggressive seeing these data. I think we could maybe have saved some kidney injury if we had been a little less aggressive with the unloading. So I think it's something that can be targeted. Maybe also moving the Impella from the groin up to an axillary placement faster could also be a way of avoiding some of this where the placement is better and there's just less complication when it's has a stable position.
And do you know the long-term outcomes of those patients who did experience kidney injury? Were they mostly on dialysis in the long run? Was there renal recovery?
We saw recovery in all. So at 6 months, we had no patients that went on renal replacement therapy. They did not remain on, but some of these patients that went on may have died because renal replacement therapy is a risk marker in these patients. But we didn't see long-term need. So at 3 months, there were 2 patients, as I recall, still on dialysis, and 6 months there were none. And that is, of course, reassuring, but I still think we should take this signal of kidney injury very, very seriously. We did not see any interaction with the effect of the impeller. So we still had the same risk reduction, but in those on dialysis, but we saw higher mortality. So we have to address it.
No, I think that makes a lot of sense. So we have a question from the audience. So our good friend, Dr. Katz, is joining us, and he wanted to ask, maybe we'll start here, Jacob, with you, do you think of Danger Shock as a device trial, as a strategy trial? What are your thoughts on when you were conducting the trial and deciding on the protocols?
I think it's a strategy trial. It's a strategy of putting this device in very, very early. I never really saw it as a device trial. So for me, it's much more the strategy of very early on unloading or supporting the circulation when we're sure that the circulation is dropping.
And Balim, we are doing lots of work coming up on cardiogenic shock, as well as critical care cardiology. We were talking about heart failure shock and AMI shock. What do you think we can learn from Danger in terms of putting it to the future trials that we're going to be doing?
Yeah, I think phenotype is what we can learn from Danger Shock, that there's definitely work that needs to be done on our part to better understand the phenotypes of our patients, to really be able to say what they will benefit from, whether chemical support or mechanical support, what strategies and when those strategies should be deployed to better help them. But I think better understanding our patient population and better bucketing them is going to be really the future, being able to deliver better therapies to them.
So one of the comments that was brought up after Danger was the differences in outcomes between gender. And, we have seen this in other trials before. The partner trial did not show any difference in outcomes with TAVR between men and women. The original shock trial didn't show a difference in outcome of revascularization between men and women. But these are clearly sub-studies of small early trials that met their primary outcome. And I think that, those are important takeaway messages. But at the same time, there's anatomic reasons that may preclude women to having more complications, particularly vascular access complications and bleeding when using these devices in cardiogenic shock. So maybe, Jacob, we can start with you. What is your practice like, and what insights have you learned from the trial on the use of mechanical circulatory support devices in women?
Yeah, it's a great question, and very important. From the beginning, when we saw that there was apparently no effect of the impeller in women, my thought was it's smaller hearts, more complications, poorer placement of the device. But what turned out is really that women are 10 years older in this, and that makes a lot of difference. And women had much longer time before arriving at hospital. So men had around 3.5 hours from onset of symptoms until being randomized. And women, it was almost 9 hours. And I think this makes a huge difference. So the time to revascularization was almost 3 times longer in women than men. And I think that explains a lot of the signal we saw there. But it's, again, as I said, it's something we're diving into and we'll be elaborating more at that TCT.
And Balim, any thoughts on that from your standpoint?
I mean, I don't have much more like enlightening points other than I do think both women's arrival to care, but once they get to care, how they're treated in terms of systems of care, and then in the U.S. side, I think same thing would argue for minority populations. I think there's differences in how we deliver care to different populations that will ultimately show signals in difference in how they respond to different therapies because of where they are in their disease state.
Yeah, no, I think it makes a lot of sense. Jacob, this is the first time I've heard that the women actually were 10 years older. And I think that really could explain a lot. We've seen across so many different, observational and even randomized trials that age is likely one of the largest predictors of outcomes when patients present in cardiogenic shock, even across all SCAI shock stages. Age was always a modifier that associated with the worst outcomes. So is that something that you have noticed in DanGer as well?
Yeah, and that's and we do see that the effect of the device seems to be less in the oldest patients. So patients around 80 years or older did not benefit from the impeller, and that's also something that we are working on, and we are close to submitting the first manuscript on that. And I think it's a very, very important message that we may even harm these patients with the device.
So I think you alluded to it before, Balim, is that, there's differences in processes of care between the United States and Europe. And I think that, we now have trial data, in DanGer that shows the benefit of MCS in the select patient population. But our healthcare systems are so different. And, how do we best implement what we've learned from research and from the trials into clinical practice? For example, Denmark, and Jacob, please correct me if I misspeak in any way, there were 4 major hospital centers that were really the heart of DanGer shock, where the vast majority of shock was coming to these 4 centers. And, in Detroit, for example, I have 4 major centers that treat shock with Impella and ECMO and all of these other devices, all within our just neighborhood within Detroit. And so there's clearly, really big differences about how to create these models. And so maybe Balim, and then after that, Jacob, maybe you can just comment a little bit on future directions of cardiogenic shock care, both in the United States and overseas.
It's a really tough question. I think there's not only a difference between how we provide care between Europe and the US, but I think we're all very, palpably aware that even within the US, we have very big differences in terms of how we take care of patients. There are centers that are very balloon pump heavy. There are centers that are very Impella heavy, ECMO heavy. And I think there is a lack of heterogeneity in terms of how we go about process of care. I really wish I had a great answer in terms of how to circumnavigate that and be more uniform in how we deliver care. I do think that cardiogenic shock teams and having multidisciplinary discussions about these patients rather than an individual's preference, or an individual's preference of one device or the other, is one step towards unifying and protocolizing the care that we deliver. But I don't think it's imminent, I will say.
I don't have many more wise words on that. It's really tough. I think a lot of this is about experience. It's not straightforward treating these patients, and you need a team that is used to it and used to the device and can pick these subtle changes up in motor current when the suction begins to come. And so I mostly think, if I don't care much about how big the hospital is, it's just that the experience is there. It's really, really important, and we need to harmonize our protocols also on anticoagulation, and there's a lot of work that has to be done there.
Yeah, I completely agree. And I think it's really an important point. I mean, and I think you two have been leading this space in a way that many others haven't. But, we think of sometimes, especially in AMI cardiogenic shock, solely what happens within the cath lab. We talk about the revascularization and the placement of hemodynamic support devices. And you both are just, wonderful examples of the importance of the need for critical care. The vast majority of time, these patients are being taken care of in the intensive care unit. That's where you're experiencing the complications, and that's where you're doing most of this management. And so maybe for just the last comment is that maybe you can kind of extrapolate and discuss a little bit more on where we're going as a field, particularly with shock teams and MCS management and the field of critical care. Balim, do you want to start us off?
Sure. I mean, I'm definitely biased in terms of my passion for critical care cardiology, and have had the pleasure of being in my training as this field evolved. I do think that the future of our field is really multidisciplinary, that being interventional critical care cardiology, heart failure, and I think as it evolves, I think we'll see shock teams being more prominent in this field. I think one part of as I go through my critical care training this year is not just learning how to take care of devices or ventilatory support, but really also understanding the processes of care, and being able to speak each other's language is what I think, at least the critical care side of cardiology, I think brings, and is really important in terms of unifying our field and better caring for our patients.
I just echo that. I think it's all about teamwork. That is the key to success in these patients, and that's how we should go forward.
Yeah, no, I echo all of your sentiments. I think this is really the team of teams approach, that this is why we're making a difference, both on the clinical side and as well as on the academic side with all of this amazing work. So I think I want to just thank you both for joining this webinar. I think it's been really fantastic. We've learned a great deal about where we are. Jacob, thank you so much for really all of the hard work that you and your whole team have done. It is not easy to do a trial for 10 years and to be patient and to slowly expand that trial to other countries. And after 30 years, we have a trial now that is changing the field of AMI, cardiogenic shock, and we have you and your team to thank for that. So really fantastic. Thank you to Radcliffe for inviting all of us to be a part of this. Thank you to the audience for all of the insightful questions, and we hope that you'll join us in future events. Thank you so much.